I would again like to just acknowledge the named individuals. We have these 3 important named lectureships, and so just briefly, I'd like to acknowledge Dr. Claude H. Organ. Dr. Organ, as I was going through this, summarizing of physicians' accomplishments in 1920, because there's less documentation of what they've done, and maybe they were, not quite as accomplished as when someone has to recapitulate the CVs of children that are in school right now. I feel sorry for them because they've all saved the world before they went to junior high. But that is Dr. Organ. So summarizing Dr. Organ's accomplishments in just 3 slides is a little bit embarrassing, but he did go to Xavier University, got his medical degree at Creighton. He did his residency at Creighton and then stayed on faculty for some time and became the chair of Department of Surgery at Creighton in 1971. He is credited for developing 2 surgical residency programs, one at Creighton and one at University of California, Davis. He's founding member and one of the original founders of the concept of the Society of Black Academic Surgeons. He established the University of California, San Francisco East Bay Surgery Department and was the department chair there from '89 to 2003. He was a site visitor for the Liaison Committee on Medical Education, member of the Residency Review Committee for Surgery, chairman of the American Board of Surgery, editor of Archives of Surgery for 15 years. He was given the most distinguished award from the American College of Surgeons in 1999, the Distinguished Service Award, and then subsequently was the president of the American College of Surgeons. Dr. Organ has over 250 published scientific articles and book chapters, 5 books, and is well known for fighting tirelessly for the inclusion of African Americans, other minorities, and women in the training and practice of surgery. And he was also well known for being very dedicated to surgical residency training. In the Southwest Surgical, he's important. He was our 37th president at the Las Vegas meeting in 1985. Thomas Russell wrote a summary in JAMA Surgery and said his presidency of Southwestern Surgical, marked by significant changes of the association's policies, programs, and initiatives, are the reason that we recognize him and his profound effect on Southwestern Surgical with this named lecture that started in 1996. His son wrote a summary for, I believe this was for the AMA, and he wrote that Dr. Organ was a keen listener. He would consider many angles to aid one in assessing a problem, identifying relevant options that led you to an appropriate conclusion. Armed with an agile mind and a firm sense of himself, there existed strong moral foundation within about right and wrong. He possessed a quick and uncanny ability to get to the heart of an issue, telling it like it is, but in a calm, cogent manner. You will make mistakes and fall down. The question is, what do you do when you get up, and how do you respond to that disappointment? I thought all of those quotes were apropos for a debate. So if you'll open the Attendify and get into your poll everywhere, we'll open the poll for the debate. The debate is, should we use Reboa in the resuscitation of a critically injured patient? And so here is the case that I sent our debaters. Again, I'll give you the disclosure that we assigned these gentlemen their pro or con. We'll ask them to get their final opinion at the end of the case, but whether they're arguing for Reboa or against Reboa was the assignment which we had given them. So the case is a 56-year-old woman. Oh, that is not the case.
Wait a minute, that's not what I'm doing.
That is not the case.
You seem to have a problem.
I did this last night right before the cocktail party. I'm like, I forgot something. What did I forget? Gentlemen, can you remind us of the case?
Yeah, so the case is going to be a 28-year-old male who sustains a gunshot wound to the left upper quadrant. He arrives and he's found to have a second hole in the mid-back thoracic region. He arrests on arrival. Now what?
So the patient has an entry wound in the left upper quadrant, an exit wound in the upper chest. He was hemodynamically unstable in transport. He's now in the emergency room and arrests. Would you use Reboa? That is the case. So we have Dr. Hahn. Dr. Hahn is a professor of surgery in Denver.
Nope.
No.
Katy, Wichita.
At Wichita. Oh, I have that right here. My screenshot's down just too far. I'm sorry, and I have it right on the screen. So Dr. Hahn is a professor of surgery in University of Kansas, Wichita. He is the director of trauma at Wichita.
Yes.
Is that accurate? Yes, sorry. And Dr. Kim is a professor of surgery at Harbor, UCLA. He's the vice chair of College of Applied Anatomy at UCLA and the director also of the ICU and the Critical Care Fellowship. And do we have the results of the poll? So 24 voted, and
I've got some work to do.
the majority of you said that you would not. And so we'll start with the pro argument.
All right. Good morning. I'm Jim Hahn. I have the pro, but I actually like the pro argument. I'll just say that up front. And I wanted to talk a little bit about the conversation. Yeah, I was trying the wheel, sorry. Sometimes it's good to step back, and we're using words, but what are we really talking about? Is it reasonable to supplant the ED thoracotomy, one of mine, a clamshell, with this occlusion balloon, all right, the Roboa? When I first thought of this, we have several people I think would be better to stand here than me. That being said, don't shake your head at me. But then I thought about it. I was actually initially a critic of Roboa, to be fair. When you said you're going to take this balloon, you're going to take a dead person, you're going to cut down on the groin, you're gonna, or I could just open his chest, I'm just going to open his chest. My mind was at least opened when they switched over to the low-profile system, and I have nothing to do with prime time or any of that. This is just my own opinion. When they did, I thought, again, maybe we need to reevaluate this technology. The decision anybody makes as a director of a trauma system is, does it work? If it doesn't work, I don't want it, and there's a disparate version of it works or it doesn't work at all. Can my team do it? You know, I used to be a shock trauma, but I'm not anymore. I'm in Wichita, Kansas. My resources are far more limited, so maybe it works great in the big city, but it isn't going to work for me. And how can we do it? And to be fair, you guys write papers on this is how we do it. That is not how we're going to do it in hybrid systems, smaller hospitals. It's just not going to be the way that you guys are going to go about it. So let's start with the first one. Does it even work? Because if it doesn't, this is easy. I don't have to talk about it anymore. As you can see, even today, there's very many different opinions, and those of us who are outside the dogfight don't really know what to do. This is one of the rare instances. I actually started looking at statistical papers and meta-analysis, which are not my favorites. But one of the better ones from Menenzo from World Journal of Emergency Surgery did a meta-analysis looking at resuscitative thoracotomy versus Roboa. Let's look at all the big databases, pull these out, have human beings, two different reviewers, look at the papers, say, is this really Roboa? Is this really resuscitative thoracotomy? And is there just massive bias in it? And if it is, we throw it in the trash can to begin with. If we're not sure, there was a more senior reviewer who would come and look at it and say, you know what, you're right, you're wrong, we're moving on. Because so many of them are retrospective, and retrospective, as we know, has a lot of built-in biases, selection bias, survival bias, etc. They actually use a system called minors to go in and look at data validity. And if it went in and said the selection bias or any of the above was too high, it goes in the trash can as well. It also had a series of methodologic systems to look at that. I felt like my own thoughts were confirmed when it went through all of these, and basically we ended up with 2 papers that were retrospective and 1 prospective. That's what they came away from all this data we've been reading all this time. And looking at that, that still is 1,276 patients, and they looked at mortality and they looked at complications. If we compare these, resuscitative thoracotomy group, 403 patients versus 873, transfusion 74 versus 85%. Initially, they talked about an odds ratio of 0.4 as far as the mortality, but then they again used more robust statistical areas looking for bias and found that it really wasn't significant. You couldn't use that number, but you could use relative risk reduction, and that dropped it to 0.81 if we threw out some of the data from one of the papers down to 0.76. Angio 10% versus 26%. I was truthfully surprised there was any angios in the resuscitative thoracotomy group. And the real takeaway, mortality, which wasn't dissimilar to the Dr. Yamamoto's paper he just presented, 78% versus 60%. So a pretty significant decrease with very, very robust statistical analysis. So that was one of my takeaways. My other takeaway, being a skeptic, that's a whole 3 papers. That didn't make me feel warm inside. So if we looked at that, a larger group, looking at everybody, not just trauma, with expanded databases, sort of a similar design, 3 authors, 1 tiebreaker. But they also looked at things that I was really hoping for, which is balloon characteristics, and where did you put it? Is this really a Roboa, and how did the pressure change, and what was the physiology? They used the Cochrane tool, 6 domains, as we all know, That left them with 89 studies, 1,482 patients. More importantly, for what I cared about, that still had 18 studies in trauma. 870 patients, 91% were in shock, mortality 63%, which sounds amazing to me. Risk difference at 0.27, and interestingly, the ones who got the Reboa, their pressure went up by about 80, as opposed to the ones who went in for ruptured AAAs that I didn't look very closely, but theirs went up by about 50, so it does seem to work. So if I've decided now it does work, I'm willing to go to administration. This thing costs a lot of money. It costs a lot more than balloon occlusion catheters that the vascular guys use, but I really think we need it. It's a not-for-profit Catholic hospital, so that's always a tough discussion to have. Can I actually use it here? For those who don't know, KU Wichita is a hybrid program, right? We have an academic component, but we usually train people who go out in the world and do general surgery from day one after they finish up their residency. The good side is we have lots and lots of volume. All the lines are ultrasound guided, and I think that's critical. You have to be able to do ultrasound guided lines to make this work. If you can't, you have to figure out how to do it again. Otherwise, you're wasting your time. We have a very robust endovascular service, and there are no fellows. So truthfully, most of the Reboas I put in, the residents like, now what? It's like, no, that was it. Oh, really? Okay, I stand aortas, but that was nice too. My bigger problem is I've got 6 trauma surgeons, critical care boards. None of us trained when Reboa was. I wasn't at shock trauma when they had Reboa. I'd left long by that point, so I didn't know a lot about it as hands-on personal experience. So you have the problem of additionally telling this to a group of the 6 of us. Yeah, you're the boss, and I'll tell you truthfully, one other trauma surgeon said, yeah, this is great, I think it's a really good idea, and 4 other people kind of looked at me and said, well, if you say so, I guess we'll talk about this. So I had to figure out, one, am I going to get buy-in? This is going to be a waste of time if I do this, and none of my surgeons actually want to do it. We can look at the best study, and as you can see, hopefully here, time 0, 6 months. At third 6 months, you have buy-in. In fact, they're preferentially doing the Reboa over the ED thoracotomy. So that was somewhat encouraging. How quickly can we do it? Again, this is looking back at the best system. When they timed people, 10 general surgery, 10 general surgery critical care, 1 general surgeon cardiothoracic, 2 fellows, 2 odd things they had out there, ED people who also have surgical critical care boards. And you can look at the over 6 trials, there's a rapid decrease in the time it takes to successfully deploy the balloon in zone 1. They also looked at the people, and some of this is very similar. 8 years since residency, a few people know a lot about endovascular, but some didn't do any. A few aortic balloon pumps, but everybody, and I want to emphasize this, is putting in at least 3 lines under ultrasound guidance a week. We do a lot more than that, but if you have a 0 there, I wouldn't do it. The other thing in the selfish part, I live in Kansas. There's a giant frontier area. Someday I'd like to have it that people put Reboas in these little hospitals, and by little I mean the level 3 trauma centers, and then ship them to us so I don't get somebody on the helipad who's a warm autopsy. How are we going to make that happen? And that one I deferred it to the military experience. They had a workshop, 10 special forces medics, 5 combat nurses, 4 non-surgeons, and then the 4 military surgeons as control. It encompassed anatomy, especially for the special forces medics, the equipment you're going to use, and how to do the Reboa. Median sheath time, not surprisingly, special forces medics about 4 minutes, nurses a little under 3, 2.5, and our control is 1 in 40 minutes. Reboa inflation time, I was very, I won't say surprised, but impressed, about 5 minutes for a special forces medic, 4 minutes, 3, and then a little over 2. The other, it's all about access. Again, we have one of the authors right there. Retrospective video review of Reboa versus resuscitative thoracotomy. If it's de novo, the resuscitative thoracotomy is faster. Most of your time is getting that femoral artery access, 247 seconds. I found it's interesting, it's not my experience that I can do a percutaneous at the same time that I can do a cut down, but that depends on what you have as your skill set. Again, the zone time is not that much, so 245 seconds. So that was the other component of ours. If we're going to do this, we need to put it in preemptively in these cases. When they come in full arrest, yes, we still do them, but that's not your main market share. And we know from the Japanese experience, picking this, looked at 109 patients, about 50% deaths. Survivors obviously had less CPR, better systolic blood pressure, occlusion times were shorter, 35 versus 63 minutes. I found it interesting, they talked about an inflection point for time. How much time do we have to do this? And they found up to 21 minutes you would have fairly equivalent survival times. After 21 minutes, add 10 minutes, 10% more people die. I like things that are simple to remember like that. Now the other half of the Kansas part, which comes up, and occasionally for other things, and I have personally experienced, and I've asked quite a few of the people who do lots of Reboa, generally if the Reboa is up for 60 minutes, they die. That just kind of is. I've tried a couple of these, I haven't had any successes with them either. So what is our alternative in a country or a place where my last critical transfer took 3 hours would be, do we have some form of partial Reboa or machinery-based Reboa with some flow? I looked at 2 main study designs. They're all based on pigs. 25% blood volume out, 45 minutes of occlusion with a mechanistic system to allow 100 to 30 mils of distal flow using the evac. At 65 minutes, transfusions return to 60% of blood volumes, and then they deflate over 5 minutes. And what they found was, yes, the total occlusion, you get a better pressure, which I don't necessarily want at that point, but you cut your crystalloid fluid in half, 7 down to 3.5. Norepinephrine dropped from 50 to 25 in the post-resuscitative period. And lactates high went down to 3 for the partial Reboa, the evac Reboa versus 5. And similarly, if you don't want to use a machine, the partial Reboa, where you're physically moving the balloon up and down for pressures, they bled everybody down to 50 millimeters of mercury. Want a target blood pressure of 80 over 100. You have the Reboa, you have the control. They sent a slew of biochemical markers to look at this more in depth: intestinal microdialysis, intestinal perfusion catheters, histopathology, etc. And what they found, not surprisingly, was lactic acid 2.8 if you had this partial Reboa, manual partial Reboa, versus 5.4 if you just completely Reboa'd, versus the 2.3 at baseline. All of these markers were much better in the partial Reboa, not surprisingly, because there is perfusion versus the other. So this gives me some hope way down the line, and I've already gotten into talks with some of these hospitals that if they can learn to do Reboa, that maybe they can keep them alive long enough for a Kansas transfer time to be alive when I get them, that I don't just have this dead cadaver that I release the Reboa and they die of declamp shock is what I would call it. So we look at this case. Now there are some caveats to it because of where that other bullet comes out. What we would do briefly is rule out a thoracic component. That means fast, no tamponade, no effusions, chest x-ray, no big wide mediastinum, and I'm not overly concerned trajectory. From what I understand of it, we didn't get any pictures, but if those are all true, I would do the Reboa, although truthfully, I would also prep the chest at the same time, because if they're having issues with access below, that's usually the second year, then we'd start to open with the fourth year above. So I'd have a very, very short period of doing the Reboa. But that being said, if we think about the different pictures, well, we'll come back to that in a minute. If we look at the different pictures, everybody's done ED thoracotomies. They're big, they're bloody, they're messy, the residents love them, I got that. But it just intuitively is obvious to me, if I have two things and I whack open a second cavity, it's got to have a negative effect as opposed to just putting this little balloon up. Maybe there is an effect, obviously. There are amputations, there is kidney failure. I know there's a couple things we'll be going over. I felt like not doing that, I'm saving it for the rebuttal. But to me, it makes sense if you rule out the chest injury and if you can rapidly get access to the common femoral artery, or even better, catch the transient responders before they go down. What I can say from my own experience being a skeptic, I did ultrasound everybody who's had a Reboa, and so far I've had one person with minimal narrowing, no hemodynamic effect. So we haven't seen any of these horrible things happen. I don't doubt at some point they will, because they will. They have a cost. But at least in our case, we haven't seen it with the new system. If we're able to increase occlusion time, and this is the big one for the people who do all this research, please do this, because I'm in a place I need it. Nebraska's a place. Everything that you look at the Rocky Mountains and the Great Plains, there's a giant chunk. We absolutely, if you can make partial Reboa work and give us more time than an hour with occlusion time, it will be greatly utilized and probably a lot more useful than in the major centers, I'll be honest. I thank the Congress for the opportunity to present. I also thank Dr. Kim. We hadn't talked much. It's been very nice talking to you. I did not put anything nasty in. If you did, I will deal with it, as a la Sean yesterday. I considered it briefly last night adding it, but I did not. And we'll talk a bit more. Thank you.
Good morning. I'd like to thank the program committee, firstly, for the invitation to speak to you today on the pitfalls of Reboa. Thank you very much, Dr. Scaife. And I'd also like to thank my co-presenter, Dr. Jim Hahn, for a very nice presentation. Balloons and inflatable devices, these aren't new to surgeons. Whether you're a trauma surgeon or a general surgeon, intragastric balloons, mask trousers. These have all been tried, tested. Oftentimes, these are met with open enthusiasm, arms wide open, and it's only after a period of gaining experience and understanding that these are not benign procedures. A needle going into a blood vessel is not a benign procedure. There is an increase in potential complications, adverse events, and it's only then that we kind of take a step back and say, whoa, 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 does this actually make sense what we're doing? Balloons are not benign, and I think the nefarious nature of balloons in general has been understated. So getting back to our patient, this patient has a gunshot wound, comes in through the left upper quadrant, out the back. You don't need to be an anatomist to realize that this patient's in a lot of trouble. He could have a cardiac injury, he may have a great vessel injury, he may have intrathoracic injury. This is a thoracoabdominal wound, and this is probably the last person in the world that you want to be putting a Reboa into. So we do Reboa. Can I see a show of hands, the trauma surgeons, acute care surgeons, and vascular surgeons in the room? Hands up. Perfect. And if you're doing Reboa, keep your hand up. Okay, so still a fair number. We're fairly early adopters of Reboa. We started our program back in spring of 2014. Over the last 5 years, we've done about 28 Reboas. Remind you, that's in the setting of seeing about 4,500 trauma patients a year. And overall, these patients, when we kind of just do some basic stats on them, descriptive stats, they're sick, ISS of 34 median. Amazingly, about 2/3, and I think you'll see this across studies, end up in an operating room. They're either undergoing a laparotomy or a thoracotomy or both, and mortality is still pretty high. Interestingly, the complication rate is also quite high, and as we go through these slides, I'm going to show you that the complication rate, both in terms of organ failure as well as the risk for amputation and limb loss, is substantial. So here's the 5 reasons why Reboa should not be used in the trauma bay. Number 1, it has extremely limited applicability. Number 2, it's not superior to resuscitative thoracotomy, and in fact, probably shouldn't be compared to this life-saving procedure. It also delays the inevitable. It doesn't improve survival. And then, like I've mentioned, there is an increased risk for complications. This is the Reboa algorithm. Hypotensive patient, blood pressure less than 90, get access. And what I find really interesting about this algorithm is outside of a potential aortic injury in the chest, whether the FAST is positive or not, and whether or not the pelvic x-ray is positive or not, everyone is getting a Reboa. So I think if you really want to inflate your numbers and make Reboa look really good and associated with survival, you stick Reboa in everyone that doesn't need it. And you feel great, you know, you're giving high fives, wow, that was amazing, the blood pressure went up by like 50, the patient's great. This Reboa, it's a game changer. But Reboa has limited applicability. In this really nice study out of University of Pennsylvania, they actually looked at a year's worth of data, 2014 to 2015. They went through their registry, and the whole purpose of this study was to examine how many of our patients that actually come to this level 1 urban trauma center are potential true candidates for Reboa. And out of about 5,000 patients, once they sort of got through the anatomic injuries, looked at the physiology, ultimately, after 2 independent reviews, there was 29 patients. That's 0.06% of patients that come to this busy trauma center are true potential candidates for Reboa. I mean, if you go by the original algorithm, it's essentially every single patient that's not shot in the chest. But here, I think we get a better delineation of who these people are, and they're uncommon. Our data, uncommon. This center, uncommon. This study's been wrapped up. This is the double AST pelvic fracture multi-institutional study by the group out of UC San Diego. This had data from about 11 level 1 trauma centers looking at patients who are arriving to the emergency room hypotensive or tachycardic greater than 120 with a base deficit greater than 5. So these are sick, shocked out patients. And they wanted to look at the need for hemorrhage control interventions. And this is a fairly recent study, took place over about 4 or 5 years. And if you look at all the interventions, despite all the increasing popularity in Reboa and the talk of using Reboa specifically for zone 3 occlusion in patients with these horrible pelvic fractures, only 3 patients actually had a Reboa placed. What I find super interesting is they were placed in patients who had minimal pelvic fractures, an LC1 or an APC1 with the Reboa makes absolutely no sense. Mind you, the physiology or pathophysiology is important. So a lot of studies out there, and Jim went over a couple of them, where Reboa is compared to resuscitative thoracotomy. And in this retrospective analysis in Japan, they compared Reboa to patients who underwent resuscitative thoracotomy and found that there's really no significant difference in terms of the in-hospital mortality. This was not using the Japanese trauma database. More recently, we have the aorta registry, and a couple of papers have come out using this database. This is a prospective observational analysis gathering data primarily from level 1 trauma centers. And as of this publication, there was 114 patients who underwent aortic occlusion, either resuscitative thoracotomy versus, that's a Foley catheter, Reboa. And again, similar to what we've seen at our single center, 2/3 of these patients ultimately need to be in the operating room. Now, we've heard that it doesn't take a lot of time to get access and occlusion, but I'm going to show you some data that shows you that, in fact, it does take a while. And depending on who's doing it, and most of these studies, they're extremely experienced personnel who have fellowships in endovascular surgery, it can take up to 5 minutes. And that's time that could be used more expeditiously to get your patients up to the operating room prepped and stop the bleeding. Yesterday, we heard that operative case experience for our graduating residents is going down. And when you look at the actual aorta data, what we're finding is that when a Reboa goes in, attendings are much more likely to be doing that case. Of course, we need to get our numbers, we need to get our experience, but 90% of the time, it's the attending, the trauma attending, the person that's supposed to be running the resuscitation is now completely zoned in to poking this artery and getting that Reboa in. And residents aren't getting that experience. In fact, when you look at resuscitative thoracotomy, more often than not, it's going to be the fellow or the resident doing that procedure. And which one's more portable? Which one's more pragmatic? When I have a graduating chief resident from my general surgery program, they may not be in a place where they have access to a hybrid suite or vascular surgeons or a Reboa program in place. But if a kid comes in at 2 in the morning, shot through the chest with no vitals, that resident, I hope, understands how to get into a chest, identify the aorta, put a clamp on it, and get that person upstairs. So oftentimes in so many of these studies, we really are comparing apples and oranges. I actually really like this study. This is a study by Dr. Brenner looking at cardiac compression fraction and end-tidal CO2, and demonstrated that in patients who undergo Reboa, pretty much all throughout the resuscitation while they're getting CPR, the cardiac compression fraction is much higher in patients who undergo Reboa versus getting resuscitative thoracotomy, and that makes sense. You know, as soon as you take that knife out, the arm's up, and you're cutting, the heart's not pumping. So it seems to make sense that outcomes might be better. Again, the groups are not well matched. There's a big portion of penetrating trauma patients in the group that are undergoing resuscitative thoracotomy. And again, compression fraction or end-tidal CO2, there's a number of things that can affect that. And so we don't really have a sense as to the severity of thoracic injuries between the groups. Outside of just the time that you're thumping on someone's chest, you have to ask about the quality, the depth, and then there's no data at all regarding what other sorts of pharmacologic interventions patients are getting. So are patients who are undergoing Reboa getting more of a medical code where they're getting epi pushes and bicarbs? We just don't know. This study was also talked about by Jim, and again, I draw your attention to the differences in the study populations. When you look at patients undergoing resuscitative thoracotomy, the median ISS in these patients is much higher, and those with an ISS over 75%, almost 4 times greater number of patients in the thoracotomy group. So really the comparisons here don't make a lot of sense. Also, when you look at the presence of admission vitals, patients in the Reboa group, 3/4 of them had vitals on admission versus less than 50% in the resuscitative thoracotomy group. And if you look through the fine text, of those that made it to the ICU, 3/4 of patients that underwent resuscitative thoracotomy die of what they should die of, bleeding. whereas 90% of patients who got a Reboa died of TBI complications. So very different groups. I don't know that TBI is necessarily a good indication to put in a Reboa. I don't think for our patient there's a good indication for Reboa. And so ultimately, although the authors conclude that it may be equivalent in terms of overall survival, I think this study actually shows the opposite. You have super, super sick people that are getting resuscitative thoracotomy, not so sick people that are undergoing Reboa, yet survival's the same. And I think I've already alluded to this. Reboa ultimately delays the inevitable. Patients need to be in the operating room. When you take a Reboa course, which you all should, if you're going to be doing Reboa, you need to get trained and certified and understand what the risks and complications are. It doesn't look like this, right? When someone's hypovolemic, they've bled out 40% of their blood volume, they're getting active CPR, and now you've got that ultrasound on this morbidly obese groin, and you're trying to stick a little piece of spaghetti noodle. It's very, very difficult, all right? And if you don't get it on the first stick and you go through and now you got a big hematoma, you've just ruined all your chances. And so any of us that do like ECMO CPR, you know that first stick is the most important. And again, time to Reboa, time to occlusion in this study, it takes a while to do this, all right? And all that time, that patient could be wheeling up to the OR. Reboa does not improve survival. I can show you, 5, 6 of these curves, these Kaplan-Meier curves. They all look the same. And this, again, is a propensity-adjusted analysis of the Japanese trauma database. They've been collecting data since 2003. Again, only 1% of patients in this registry underwent Reboa. And when you looked at survival between the two groups, much less survival in patients undergoing Reboa. A similar analysis, this is in patients who essentially underwent an emergent operative intervention or angiocatheterization. And in this group as well, patients in Reboa have worse outcomes. I know what you're asking yourself. And yes, this is a complication of Reboa, a very, very aggressive Reboa. No, it's not. So complications, there are multiple. Balloon rupture, if you're going to do a cut down, transection of the common femoral artery, uncommon, but a zone 0 deployment, insertion into the ipsilateral, hypogastric. So again, this is not a benign procedure. There's a joint statement that was published in the Trauma Surgery and Acute Care Open where the authors, I think appropriately so, point out the substantial complication risk associated with Reboa, but in skilled hands may be more rapidly applied. Haven't really seen data to support that. And then in the most recent nationwide analysis, so we've seen a lot of Japanese trauma database studies. It's a very different system. The emergency room doctors there are putting them in. To be fair, when you look at the studies and patients who do require an operative intervention, oftentimes there's a delay of more than 1 or 2 hours to get the surgeons in and get them up to the operating room, which will certainly explain some of the differences in mortality between the Reboa versus non-Reboa group. But this study is a look at TQIP. And in this study, essentially, the major outcomes were mortality, 24 hours hospital, as well as adverse outcomes. And again, it's a very similar looking Kaplan-Meier curve to all the other ones I've shown you. Increased risk of death in patients who undergo Reboa using similar propensity matched analysis. And when you look at the adverse events or outcomes, AKI is almost 3 times more common in patients who underwent Reboa. The risk for amputation, and again, these patients were stratified and matched by their extremity AIS. And so we know that it's not the trauma that's resulting in their extremity amputations like that grisly picture I just showed you, but probably or possibly related to the actual vascular access procedure, but much higher, a 4% incidence of limb loss in patients who undergo Reboa and increased risk of death. The complication rate across studies is pretty high. And I think the point about making sure that we're as transparent as possible in collecting this data is so important as we refine this technique. But even within the aorta registry, 2.2% incidence of pseudoaneurysm in the 46 patients that underwent a stick for Reboa. as well as a higher risk for distal embolism. And in another smaller study, there's a 12.5% complication rate with 3 lower extremity amputations. So in terms of take-home points, if you want to perform a procedure that has limited application in trauma patients, if you want to limit exposure to performing a potentially life-saving procedure like resuscitative thoracotomy, you like delaying definitive management of your patients, and you want to worsen survival, do REBOA. And again,
I should have known that's what that was for. All right.
look at the difference. Thank you very much.
I would like to leave some time for some audience questions and so on, so we'll just have really short, just 1-minute rebuttals. But I want to take a little spontaneous poll, if the audience doesn't mind. How many of you would consider yourself a community or a rural surgeon? And of those, with your hands up, how many of you do REBOA? And of those who just had your hands up, how many would like to have access to REBOA? Thank you.
You're not supposed to help him.
No,
Wait,
I
okay.
wasn't.
You're supposed to be objective.
She was just interested.
I was trying to
Uh-huh.
make your point, actually.
Okay. Well, one, I learned from yesterday's debate not to put all the slides that go against what I just said, because that way I'll have to present against my own point. The one I knew that you would get into was the national analysis of REBOA. And you're right, the positive parts, it's TQIP, REBOA 140 versus 280 because it's propensity matched, 1 to 2, mortality 36 versus 53, and the complications is listed. The problem is, with that study, it's better data than most, but the reason you didn't hear me pull individual studies is they're all biased. In deference to everyone else, there is selection bias, there's operative bias, it's hard for anybody who doesn't do this for a living to look at these and say, I don't know what to do, because just like today, you've got 2 different people you think you respect saying totally different answers. The weakness of this particular study, and this would be the biggest one I would use were I sitting in the other spot, you don't have any occlusion times. I don't know how long the balloon was up. I don't know where the balloon was. Was it in 1, wrong place 2, 3? You have no hemodynamic information, and that's one of the areas that I kind of go off the rails when we talk about everybody who comes in shock should get a sheath. I didn't say that. There is judgment, and I know that sounds weird in this era, but there is clinical judgment, okay? We talk about shock and things of that nature. So we don't know. And based on that, do we really need to have every single hypotensive patient get a sheath in before you even do the fast? I would say no, so I will come off trail a little bit. And that we do use it for pelvic fractures. I know we only have 1 minute here. Using what we know, though, I'll go back to pictures since we look at pictures. ED thoracotomies are fun. They're not as resource intensive. When you go to administration and say, that thing is big and it's bloody and it's free, why should I buy a $2,000 catheter? I think it has a role. It is a tool. It will not supplant ED thoracotomy. There's no reason it should supplant ED thoracotomy. And as I told you, in somebody without a pulse, I'm going to be ready to do both. And if it's taking longer, and this is usually a second-year resident, which I think is different than what you're talking about, the 2 is in the groin, the 4 is salivating, hoping the REBOA isn't going well, so they're going to open up the chest, and I'll jump over to the chest instead.
Dr. Kim, your rebuttal?
Yep, sorry. Jump. I thought we got 3.
Thank you very much, Jim. I think you make some very valid points. Again, when it comes to the studies and the literature, I think the way that you kind of approach it with the systematic review and meta-analysis, again, those are only going to be as good as the individual studies that are included with them. And like you've already mentioned, publication bias, journal bias, indirectness, heterogeneity, all those things that we use to measure qualitative sort of goodness of studies really don't apply to most of these. There is currently a prospective randomized controlled trial of REBOA happening in the UK. We'll wait to see what the results of that are. And until then, unfortunately, in the absence of strong quality RCTs, and it's so hard to do in this sort of study population, we are going to have to rely on our retrospective data. And I think sort of using statistical techniques and modeling like things like propensity matching does help to control for residual confounding, and then doesn't take away the ability that once you've matched them, you can still adjust for confounders. Thank you.
So let's reopen the poll. Heather and Chris, if you don't mind. So in this case, a gunshot wound to the left upper quadrant. There's an exit in the chest, in posterior chest. Would you use REBOA? Chris, could you show the pre-debate poll? If you could show the post-debate poll. Thank you so much. Let's give a round of applause to these gentlemen for volunteering their time.